Welcome everybody. I think we're going to have people come in the next minute or two. My name is Rocky Sines, and I am the chair of the medical student committee or medical student section, specifically of the MRS. I'm just going to say Michigan Radiological Society in case you don't know, and what that is we are the state chapter for the American College of Radiology. ACR is one of the many. This is kind of crazy when it comes to radiology, but we have over 50 radiology specialty groups. And it wins the most in medicine. Most only have 3 or 4 in a specialty. But anyway, ACR is the biggest and one of the oldest, and we are the state chapter of that. So of our state chapter, a few years ago, about 6 years ago, Dr. Danny Moff, if any of you have ever met him or rotated with him, but he decided to ask us to start the medical student section, and we've done that. And through your ideas, so our whole purpose is to promote radiology for students and to try to get you guys motivated or interested in radiology sooner rather than later. And one of those ways that we do that, ways to help you also, once you're thinking about radiology potentially, is what we're doing today. So today, it was an opportunity for you to present a project that you can actually put, in your ERAS whenever you apply to whatever, but hopefully to radiology. Specifically, but to try to help you to, increase or make your ERAS look better if your ERAS is a little bit light. Specifically, so myself, I also have a co-chair who's on with us. That's Dr. Klein, Dr. Kate Klein. She's from U of M, and she's my co-chair. Other people that I want to point out would be Dr. Vita Singh, who is our new president as of just a few weeks ago for MRS. And past president is Dr. Drew Woodward. If you ever met him, he's actually now private radiologist, but was a prior program director in the Grand Rapids program. You might have met him before. So now that you're looking at the second page here in my PowerPoint, so congratulations to our 5 winners that are there, the case presentations 1 through 5. And I want to, if you're on right now and you were not one of the winners, I would just want to say, that all of you did great. A lot of great presentations. We had almost 30 of them this year. The other 2 that don't have a number on there, those are honorable mentions that will not be presenting, but they're honorable mentions. Again, if you're one of the ones that did not win, one of the other 20 plus that did not win of those 7 names, you still would add that to your ERAS application that you've, participated in this. But so the order is on there of what we're going to go, and there's no particular order. It's just literally what I typed up the other day, no specifics. So for the 5 presenters, what you will do is you'll just share your screen, and hopefully you can get things done in 10 minutes. And what we can do is in the chat you can type in a question if you have it, while they're presenting, and then at the end they can answer your question. And without any further ado, so Dr. Klein, do you want to say something before we start? You're muted.
Yeah, I
Okay,
know. I just want to say welcome everybody. And Dr. Sines said, this was an amazing year of submissions. And our rubric for scoring this year is increasing more and more, because it's really hard to differentiate all of your fantastic submissions from each other. So kudos to everybody who submitted. And we are going to be trying to also review and see which ones we could try to post on the medical student website as well, part of MRS. And also that, if you are like an M3 or not M4, please resubmit next year too. Okay. So we really appreciate everybody's involvement, and congratulations. So wonderful to have everyone.
excellent. Thank you. So first off, and I'm assuming everybody's on, that's what Shannon said a second ago. So first we have Rija Alwan and Alondra Alvarez. I don't know how you are presenting this. In other words, if you're going to do it together or one person, but the floor is yours. So again, you just go to share your screen, and that will knock me off, and the floor will be yours when you start.
Awesome. Yeah. So me and Alondra will be presenting together.
Great.
Does that look good to everyone? You can see normal.
Yes, perfect.
Okay,
yep,
awesome.
I'm gonna mute.
So we are going to be presenting our neuro case. And so to start off with our case presentation, we have a 62-year-old male who was presenting to the ED with generalized tonic-clonic seizures. His past medical history is relevant for headaches and seizures for the past 4 years. Relevant medications include Lexapro 10 milligrams daily. His family history that was relevant was a stroke in his mother, a seizure disorder in his daughter, cancer in both his brothers that were unspecified, and then lung cancer in his sister. And then of note, he's a commercial truck driver. And so on his physical exam, his vitals were stable. And then they did a complete neural exam on him, and they found that his cranial nerves 2 through 12 were intact. And the only thing that really stood out from his neural exam was that he was ambulating with a cane for balance. And so we'll just jump into the imaging. Here's a CT without contrast. I'll give you a couple seconds just to look at it. Okay, and here you can see an amorphous area of calcification in the right temporal lobe where the arrow is pointing. And then they also got an MRI pre and post contrast. I'll give you a second to look at those. And then here you can see an infiltrative heterogeneous mass involving the right temporal lobe without any mass effect or edema or midline shift. And on the left, you can see the pre-contrast image, which shows a mildly hypointense lesion. And on the right, you can see the post-contrast image, which shows a heterogeneous enhancement of the lesion. Here is the MRI GRE findings. And similarly, you can see a focal area of hypointensity on this imaging. And then here is the MRI flare. And again, you see this heterogeneous area of mixed signal intensity. And then finally, we have the MRI coronal T2. And here again, you see a heterogeneous lesion with mixed signal intensity in the same region as before. And so to jump into differential diagnosis, when we think about masses in the right temporal lobe that could cause seizures, there's quite a broad differential diagnosis. The top ones include glioblastoma, brain mets, astrocytoma, oligodendroglioma, primary CNS lymphoma, and then 3 others could be HSC encephalitis, brain abscess, and AVMs. Although of note, encephalitis, abscesses, and AVMs tend to present differently, and they look different than mass lesions on imaging, and so those are less likely compared to the other 5. And then of note for this patient's hospital course, the team ended up consulting neurosurgery and they performed a brain needle biopsy. And the pathologist ended up doing a Congo red stain and that showed apple green birefringence.
Yeah, and so after the biopsy, the final diagnosis was cerebral amyloidoma. And a little bit about cerebral amyloidoma is that this is like a rare entity where amyloid protein deposits locally and then forms this mass-like lesion in the brain. And so, like Ridja mentioned, the radiologist who is seeing this scan put in the report to, do a Congo red staining for possible cerebral amyloidoma, and that is kind of what helped lead to this final diagnosis. And so while the imaging initially raised concern for a tumor, the pathology showed that this was actually more of a localized deposition. And so what we know about the presentation of cerebral amyloidomas is that it varies depending on the lesion location. Often patients are exhibiting signs like seizures, as our patient in this case, as well as focal neurologic deficits or headaches. And fewer than 100 have been reported in literature, which is kind of why we thought this case was so phenomenal. And it's more common in adults aged 50 to 54 with a slight female predilection. And treatment, it varies, but sometimes there's surgical removal for symptom relief and the prognosis is favorable after surgical resection. And so, again, the reason this case was challenging upon initial, radiologic reports is that because the cerebral amyloidoma can look like a neoplasm. It's often this rare mimicker of malignancy. And in this patient, the lesion was infiltrative, heterogeneous, as well as enhancing, which are all features that can make us think of gliomas like Rija attributed to, but as well as metastasis, lymphoma, or other malignant processes. But in this case, we had this imaging clinical mismatch where the surrounding brain looked surprisingly unaffected in comparison to what we would expect. And so cerebral amyloidomas can occur in multiple sites. Other sites besides the brain include like head, neck, lung, soft tissue. And it's also important to note that this is distinct from systemic amyloidosis. I know as medical students, we kind of ingrain in our brain this apple green birefringence when we're studying for step 1 and step 2. But we kind of just wanted to point out that this was distinct from that more common systemic amyloidosis that typically has a worse prognosis. And so some of the imaging clues, kind of going further into this discussion, I know I mentioned in the last slide, but in this case, there was this large mass out of proportion to the surrounding brain. And so, um, as we can see here in this image on the right that Ridja showed earlier, the brain appears relatively calm when we look at that right temporal lobe, and often the cerebral amyloidomas appear on T2 images as hypointense or heterogeneous on MRI. And this is usually because it's reflecting the dense protein deposits as well as the calcifications that make up the amyloidoma. And so, again, just some other imaging clues. And this is just another example of how we see this heterogeneous enhancement, but then it can also have low metabolic activity on PET, which pushes us further away from this being something more of a malignant process. And so some takeaway points that we wanted to make sure that everyone goes home with is that imaging findings are usually suggestive and they can point us to the right diagnosis, but sometimes this is a case where it's not always specific, and this was something where we needed to contact the pathology team, and that allowed us to get definitive diagnosis. And so when an amyloidoma is suspected, make sure to mention this on the neuropathology, make sure to mention this to the neuropathologist, because the Congo stain can be ordered. And something that Ridja and I learned in all of this is that the Congo red stain is actually it's easy to stain the sample, and it's a lot harder to put the Congo stain once the biopsy has been read. And so one thing that we kind of walked away as a teaching point as well was that, like, okay, even though this is rare, if we were to ever suspect it, it would be worthwhile to include it in the report. And so that was the key finding here. And the clinical course, as mentioned, it's often benign or slowly progressive, but it may be managed with observation alone, or if there's a lot of symptomatic, things that are worsening a person's quality of life, then surgical resection is an option. And ultimately, when imaging suggests malignancy, but we see that the brain appears relatively unaffected, which kind of contradicts what we normally would think of when we see mass-like lesions on scans, consider an amyloidoma, and the treatment options will vary significantly from patient to patient. And that was our short case. Thank you.
Ridja, Alondra, great job. Next up, we have Kate Workman, and she's from Oakland University. So Kate, just share your screen.
Okay, are you able to see it?
Yes, just maybe enlarge it. There you go.
Okay, I am presenting an interesting head and neck case. Before I get started, I just wanted to thank Dr. Horsley and Dr. Khan for helping me get this project started. So my presentation starts with a 8-year-old boy with no past medical history presenting with right-sided ear pain. He was diagnosed with otitis media and prescribed amoxicillin and otic drops. At home, he was able to play without difficulty, but his mom noticed that he started walking with his head tilted to the right side. And later that night, he developed a severe headache, which was localized in the right temporal area. So the next morning, due to persistent pain, he presented to the emergency department. And at this time, his right tympanic membrane had no signs of infection, and there were no labs or imaging done at this time. He was diagnosed with an inner ear infection and was put on antibiotics and discharged the same day. The following morning, his pain had worsened, and so his mom took him back to the emergency room for a second time. At this point, labs were done. He was found to have microcytic anemia, but he did not have a high white count, and his platelets were normal. A CT was performed in order to rule out mastoiditis, and it was normal. The diagnosis was still inner ear infection, and he continued on antibiotics with a new otic drop added. So about a week later, he was still having this right-sided pain. And so his mom brought him in to see his primary care physician, where at this point, his right tympanic membrane was now described as being erythematous, but on physical exam, there were no other signs of infection. There was no labs or imaging done at this visit, and the diagnosis stayed inner ear infection, and antibiotics were continued. The next morning, he started seeing double, and so he was brought into the emergency room for a third time now. At this time, no labs were ordered. He did have an MRI and MRV done. On MRI, they noticed that there was enhancement of the right petrous apex with extension into the right cavernous sinus, consistent with petrous apicitis. There was also a 60% stenosis of the right distal petrous artery, consistent with vasculitis. The MRV was done to rule out a cerebral venous sinus thrombosis or cavernous sinus thrombosis and was negative. So given the patient's findings on MRI with the sixth nerve palsy, his symptoms were attributed to Gardino syndrome. So on MRI, we're able to see petrous apicitis here. There's an increased fluid signal, also with surrounding post-contrast. Oh, whoops. Sorry, I don't know what I did. So on this image, we have a better view of cranial nerve 6, our abducens nerve entering in Dorello's canal, and you can see the close relationship that that has with the petrous apex. So Gardino syndrome is inflammation of the middle ear that extends into the petrous apex of the temporal bone. This presents with otitis media and is accompanied with facial pain due to irritation of the trigeminal nerve in Meckel's cave and ipsilateral abducens palsy from the abducens nerve in Dorello's canal, causing diplopia and lateral gaze limitations. If the infection extends further, there may be additional symptoms due to vestibulocochlear irritation, such as hearing loss and vertigo, and due to facial nerve irritation with facial muscle weakness. Here's an image to better show how the anatomy is affected. So the infection will start in the middle ear, and when it travels to the petrous apex, you can see the close relationship that that has with the trigeminal nerve and also the abducens nerve here. And just to also point out, the facial and vestibulocochlear nerves are right in that area as well. So CT is often used to get a better view of the bony features. Here I have a normal CT, and the blue part right here is the petrous apex with no damage. So in petrous apicitis, a common finding is irregular lytic destruction, which you can see here. So MRI is really used to differentiate petrous apicitis. On a T1 weighted imaging, you can see a low signal with irregular enhancement. And on T2 and on FLAIR, there's a hyperintense lesion on here and then on the FLAIR. So the MRI is really used to further describe and differentiate lesions that are within the in the petrous apex. So here we have a T1 image of our petrous apicitis, which is there on the left side. The most common lesion found in the petrous apex is a cholesterol granuloma that can be seen right here. On T1 weighted imaging, this will be hyperintense, which is how it can be distinguished from petrous apicitis. A cholesteoma is another common finding in the petrous apex, and this will also be hypodense on T1 weighted imaging, but can be distinguished because it will not have the fluid enhancing. So some complications that can be with Gardino syndrome. The most common complication is cerebral venous thrombosis, but meningitis, intracranial abscess, and carotid artery involvement may also be present. Cerebral venous sinus thrombosis is best visualized on MRV. Here's an example of an MRV showing a left transverse sinus thrombosis. Treatments often include heparin and sometimes for severe cases may include IR-directed thrombolytics. So in conclusion, petrous apicitis is caused by the extension of otitis media into the mastoid and temporal apex. Garndino syndrome often presents with the classic triad of otitis media, facial pain, ipsilateral abducens palsy, and CT and MRI are used for diagnosis. Cerebral venous sinus thrombosis, meningitis, intracranial abscess, and carotid artery involvement are all possible complications. Treatment is with antibiotics, and oftentimes these infections are caused by Pseudomonas, so it's important that antibiotics are chosen that have Pseudomonal coverage.
Excellent. Great job. Our next presenter is Sharia. I'm hoping I'm saying that. Sharia Chadalavada. She's from MSU Osteopathic. So just share your screen and correct me if I'm wrong, which I probably am, Sharia.
Troya, yes.
How to pronounce your name.
Yeah. Can you guys hear me and see my screen?
Yes.
All right. Okay. My name is Shreya, and I will be presenting an interesting ED case today. So the case starts with a 56-year-old woman who presents to the ED following a motor vehicle accident involving head trauma without any loss of consciousness. She denies blurry vision, weakness, and nausea, but she does endorse a headache. Physical exam shows a 4-centimeter posterior scalp laceration and a negative trauma evaluation. Her initial CT brain without contrast, which is shown on the left here, shows no bony abnormalities or evidence of hemorrhage, as well as a retention cyst in the left sphenoid sinus. Her laceration is sutured and she's then discharged. The next day, the patient returns to the ED with rhinorrhea. She states that it's now tinged with blood. Her headache has persisted since yesterday and she's now dizzy. Physical exam on day 2 shows continuous rhinorrhea that worsens with the Valsalva maneuver. So the imaging chosen to evaluate this patient's rhinorrhea is a CT cisternogram. This is an imaging procedure that involves the injection of contrast into the subarachnoid space to allow us to visualize the CSF better and see if there's a potential leakage at any anatomical defects. These 3 images below are of the patient's procedure, which is accomplished by first injecting the contrast into the thecal sac under fluoroscopy, then placing the patient in Trendelenburg position to help distribute it across the body. And then the patient will undergo CT to help better visualize the CSF. So here are the results of her CT cisternogram. On the left, we see moderate pneumocephalus within the basal cisterns. That's what the arrows are pointing to. Pneumocephalus is basically a presence of air within the cavity. This is pretty common, like after a cranial trauma, and usually small pockets can resolve on their own. On the right, we see a midline clival defect along the pontine cistern, approximately 6 by 4 milliliters. A pontine cistern is usually unpaired and filled with cerebrospinal fluid, and it's located dorsal to the clivus, as we can see where the arrow is pointing. We can also see that the CSF is flowing into the left sphenoid sinus on this right image. So this is just a sagittal view of the CT cisternogram. We can see contrast in the left sphenoid sinus with a loculated component on the left lateral margin. That's where the arrows are pointing to. This is just, again, further showing a leak in the left sphenoid sinus. So here we're comparing a CT without contrast that was done on the first day with the CT cisternogram. The leak from the left sphenoid sinus is much more prominent on the right where the arrow is pointing, especially compared to the circle that's in the left image. But I do want to note it's important to remember that there could have been progression of the injury, especially when comparing these images a day or so apart. So here we're comparing the images from a sagittal view, and we can again see obvious evidence of the contrast leaking into the sphenoid sinus on the right. There's also air present in the basal cisterns. That's the air that we can see right here. And it's again showing progression of the leak. So for this patient's operative course, she's admitted and evaluated by ENT and neurosurgery. ENT does a functional endoscopic sinus surgery, which involves a right total ethmoidectomy and a bilateral sphenoidotomy. Neurosurgery does a lumbar drain placement. Those are the images that we see on the right here. Purpose of that is to prevent any postoperative CSF leak. Cefazolin is administered throughout the duration of this patient's admission, and 5 days after the procedure, her drain is removed and the patient is discharged. So the main concern that we are discussing here is a traumatic CSF leak. It's basically a physical defect in the bone or meninges that leads to the leakage of CSF from the subarachnoid space into the nasal cavity or ear canal. This is commonly caused by head trauma following a motor vehicle accident, and presenting symptoms commonly include rhinorrhea, otorrhea, headache, neck pain, and dizziness. A few of these which we have seen in our patient. She was in a motor vehicle accident and she presented with headache and rhinorrhea. This is concerning and important to evaluate pretty immediately because of the risk of post-traumatic bacterial meningitis. The opening from which the CSF is leaking out of the patient can create an avenue for bacteria to enter and infect the meninges. There is more than one way that we could diagnose a CSF leak. I just discussed a CT cisternogram, but there also exists a radionuclide cisternogram and an MR cisternography, which leads to the question of why we are doing a CT cisternogram in the first place. So for our patient specifically, there's a lot of good reasons why a CT cisternogram is preferred. First and foremost, it has a high sensitivity, a high diagnostic accuracy, especially due to the direct contact of contrast and CSF in the subarachnoid space, and this contrast enhances the signal-to-noise ratio. And when we're specifically talking about surgical management, it allows for clear imaging, especially for surgeries like functional endoscopic sinus surgery, which our patient had. It also provides clear bony detail that's useful for operating surgeons by localizing the site and better visualizing the defect. And CT cisternogram is also especially useful for patients who have an active leak, which is seen as persistent rhinorrhea, which, to remind everyone, our patient did have active leak. And now to discuss why that a CT cisternogram is better for this patient over the several other modalities. And MR cisternography is not as great as visualizing bony detail. And in the setting of trauma, we really value being able to visualize it better to help determine surgical treatment. A radionuclide cisternogram has a lower spatial resolution, and it's more difficult to localize the defect for surgical repair. And it's more difficult to utilize with large CSF leaks, which is difficult to determine. It does have a high sensitivity with spontaneous CSF leaks, but not as high with trauma. And a high-resolution CT, while it does provide better visualization of bony detail, it can't effectively differentiate between mucosal sinus secretions from CSF fluid leakage. All of these different attributes help contribute to why we prefer a CT cisternogram. So overall, conclusion with this patient specifically, when we're suspecting a CSF leak, effective diagnosis should be made to prevent a delay in treatment. Accurate imaging of craniofacial structures is crucial for the surgical management of traumatic CSF leaks. And overall, a CT cisternogram is valuable for localizing the defect that's causing the leak for accurate surgical management. Thank you.
All right, thank you. Good job, Sharia. Next up is Mohol Mehta, and he's from Wayne State University. So again, just share your screen and unmute.
Are you guys able to see my screen?
Yes,
Okay.
go ahead.
Yeah, so my name is Mohol. I'm a med student from Wayne State, and I'll be sharing an interesting case that I saw when I was on my neurology rotation. Uh, so our patient was a 73-year-old woman. She presented to the ED after a mechanical fall from bed, and she was also noted to have progressive confusion and cognitive decline over the last 2 or 3 months, which has become worse in like the last month or so. And so most of the history was obtained from her partner. Relevant medical history is a subarachnoid hemorrhage in 2010 and some residual right-sided weakness and hypertension. And then relevant social history is that she lives with her partner and she was independently feeding, bathing, and ambulating until last month, but now she's dysarthric and oriented only to person at baseline, so she's unable to do kind of her activities of daily living. Physical exam was limited because of her altered mentation. She was oriented only to self. She had some perseverative speech, dysarthria, and her attention and concentration were pretty significantly impaired. Her right upper extremity was pretty rigid and contracted. There was no purposeful movement there, possibly from like her history of that subarachnoid hemorrhage. It was pretty difficult to assess like strength and sensation though because of her mental status. In the ED, she was hemodynamically stable. The initial head CT was negative, and then an echo showed a moderate PFO with a right to left shunt. Um, on day 2 of hospitalization, she did have an acute decline in her status. She was unresponsive. She continued to have that contracture of the right upper extremity, and she also started having some left facial twitching, and this prompted them to call a code stroke. They repeated the head CT. It didn't show any acute ischemic changes. There was no large vessel occlusion, and there was no perfusion mismatch. But then we ordered an MRI brain for further workup. So here is the DWI sequencing from her MRI. So we can see here there's some areas of diffusion restriction here in the uh, left parietal lobe. You can also see it in like the anterior left frontal lobe, and then a little bit in the posterior left temporal lobe as well on both of these slides. So there. Sorry about that. In addition, we look at the ADC, the apparent diffusion coefficient. So this just shows that all these areas with diffusion restriction on the DWI sequence, they were also dark on here, which shows that it's not like a false positive and that there is true diffusion restriction going on in this DWI sequence. So this kind of just recaps what we talked about with the multifocal areas of cortical restricted diffusion, mostly in the left hemisphere. There was no gyral swelling or pathologic enhancement on MRI. And then we also did see some chronic findings of left encephalomalacia in the thalamus, and then some ischemic changes and old infarcts. But the main takeaway was the restricted diffusion in the left hemisphere. So there's a couple main differentials that we were focusing on at this point. I guess our top one was Creutzfeldt-Jakob disease. In that you see kind of this classic cortical ribboning, which we do see kind of around the cortex, and it's kind of multifocal. The main distinguishing feature is that you don't see any swelling or enhancement, which is true in this case, and you also don't have any white matter involvement. Another differential would be post-ictal changes. So this presents like very, very similarly to Creutzfeldt-Jakob disease, where you also have this cortical restriction and kind of that same ribboning sign. However, post-ictal changes would normally resolve in like 24 to 48 hours rather than like 2 or 3 months. And you'd also expect to see some gyral swelling or leptomeningeal enhancement. Another differential that we talked about was multifocal embolic infarcts, which can also kind of cause this bright signal on DWI. However, this would typically follow some sort of vascular territory and it would involve more white matter, as opposed to our case where involvement was limited to just the cortex. Also, we talked about metabolic or toxic encephalopathy. This could have variable findings on DWI. You can have up to 73% of cases showing this same sort of restriction in the cortex, but you'd also expect to see gyral swelling or hemorrhage. And there was no like clinical signs of some like toxic encephalopathy like Wernicke or like a specific area that we'd focus on, but we couldn't really rule it out at this point. So it was something to kind of still keep in the back of our minds. And then our final differential was autoimmune encephalitis. So in this case, you wouldn't expect diffusion restriction, but there can be like a variety of imaging findings, and you'd most likely expect like contrast enhancement and flare signal in the mesial temporal lobe, which we didn't see in this case. And then CSF would also show pleocytosis, which I'll talk about in the next slide. So to kind of do some more diagnostic workup, we did an EEG and LTM that showed diffuse background slowing, but no seizures or epileptiform activity, which kind of helped rule out like post-ictal changes. LP didn't show any organisms, there was no pleocytosis, and there was a normal glucose and protein. That sort of helped rule out autoimmune encephalitis. And then we ordered CSF RT quick, or the real-time quaking-induced conversion. That was positive, which confirmed our working diagnosis of probable CJD, and our patient was transitioned to hospice care. So, Creutzfeldt-Jakob disease, it's a fatal prion disease where you have normal prion protein that misfolds into the pathologic form, and that triggers a chain reaction where it causes a bunch of other prion proteins to form, and you get this further misfolding. Eventually, it causes neuronal loss and spongiform encephalopathy. And then majority of the cases are sporadic, and the incidence is around 1 or 2 million cases per year. 1 to 2 per million per year. Sorry, not 1 or 2 million. It's very rare, 1 to 2 per million. And the classic kind of symptoms include rapidly progressive dementia over weeks to months, as we saw in this case. You can also get myoclonus, visual or cerebellar signs, and akinetic mutism. So the diagnosis is mostly based on clinical criteria, MRI findings, and then the CSF, as we talked about, but you can only definitively diagnose with brain biopsy or autopsy. So as we kind of already talked about, CJD was favored because of the like non-vascular distribution, and you had like those multifocal areas of restricted diffusion. There was no enhancement or gyral swelling, and kind of the clinical symptoms of the subacute rapidly progressive dementia is pretty consistent with it, as well as the CSF findings and the no evidence of seizures. So this kind of just walks through the like appropriate imaging that we should order for this case. And for rapidly progressive dementia, MRI is probably kind of the best way to move forward because CT doesn't always catch things, as we saw in this case. So there is no disease-modifying treatment for CJD, and most patients die within 12 months of diagnosis. So supportive and palliative care is kind of all we can really offer. So in our patient's case, we found that the RT quick was positive on hospital day 20. And so she was in the hospital for around like a week after that. The family elected comfort focused care. Her code status was changed to DNAR select, and she was discharged to hospice. And then 13 days after discharge, she passed away. So the total duration from first cognitive symptoms to death was around 3 months. So our key takeaways are that CT can be normal in CJD and that MRI with DWI is essential for diagnosis. You should always check your ADC map to confirm true restriction versus T2 shine through, as I kind of talked about earlier. And cortical ribboning should always be an indication for CSF RT quick analysis. In our case, we saw cortical ribboning at her initial MRI, which was on like day 3 of admission, but the CSF RT quick didn't come back until day 20. So we were able to kind of work with this presumptive diagnosis and get her started on palliative care much, much sooner than if we had just relied on those CSF findings. And yeah, so early radiologic recognition can help expedite diagnosis and guide those family conversations to kind of make the patient as comfortable as possible. And yeah, that's everything I had. Thank you.
All right, thank you. Great job. Last but not least is Connor Latterman. So he's also from Michigan State College of Human Medicine. If so, Connor, just share your screen.
Okay, sorry. Can you see that now?
Yes, all yours. Thank you.
Okay, so I'm going to be talking about an interesting OB case. So the case involves a 26-week fetus that was referred for further imaging evaluation after a routine prenatal ultrasound identified a newly detected right suprarenal mass. So notably, the lesion was not seen on the 20-week ultrasound. And so this is the week 26 ultrasound. And you can see circled in white is mostly a cystic lesion, and the cystic part is the anechoic or the dark fluid. And then there's an internal nodule that's heterogeneous and hyperechoic inside of the cyst. And there was also Doppler done on the right. And so that is showing that the internal nodule right here is not receiving blood flow. And so this raised concern for a bunch of different diagnoses, but primarily the suprarenal location raised concern for a neuroblastoma. And that is the most common extracranial solid malignancy of childhood. And it arises from primitive sympathetic nervous system neural crest cells, most commonly from the adrenal medulla. So the location was making it a potential diagnosis. However, the lesion also demonstrated substantial cystic morphology, and the margins were smooth. So that was somewhat atypical for an aggressive fetal neuroblastoma. Additionally, originally a teratoma was an option because it was cystic and had a mixed soft tissue appearance on the inside. And then finally, also a hematoma or adrenal hemorrhage was a possibility, although the internal nodule would have been atypical. So the next step was going to a prenatal MRI of the baby. So the MRI demonstrated a well-encapsulated right retroperitoneal mass with predominantly T2 hyperintensity. So that's circled right here. And then you can still see the internal soft tissue component that has intermediate signal. And then importantly, there appeared to be internal organization inside of the lesion rather than completely disorganized. And additionally, it appears as the lesion is displacing the adjacent structures rather than invading through other tissue planes adjacent to it. So at this point, the presence of organized internal morphology began to shift the differential away from an aggressive neoplasm and more towards something that's like a congenital developmental process. And this is kind of just summarizing the findings. But again, in summary, it's a complex encapsulated cystic mass in the right retroperitoneum. There's some fluid, but there's also some solid components inside, and it's displacing tissues around it and not invading. So now we're comparing the prenatal MRI on the left to the postnatal MRI on the right. And you can see that the cyst and the internal nodule have grown significantly. And again, despite that increasing size, the lesion is still smoothly encapsulated. You can see it's not really invading tissue around, but it's displacing downwards. So the right kidney has been displaced down, and we can see loops of the bowel have been displaced over to the left. So this pattern, it's much more compatible with a developmental anomaly again, rather than an aggressive malignant process that's invading local tissue. And so now the differential diagnosis has changed a little bit. So again, we are still considering neuroblastoma, mostly because of the suprarenal location. And on imaging, neuroblastoma classically appears as a heterogeneous mass, and it may have areas of hemorrhage or necrosis or calcification. And MRI, it often demonstrates T2 hyperintensity, but importantly, neuroblastoma frequently demonstrates aggressive features. So you might see vascular encasement or infiltration into surrounding tissues, which we are not seeing in this case. And additionally, the organized tissue in the middle is not very characteristic of a neuroblastoma. Teratoma was still also considered, and teratomas are germ cell tumors composed of tissue derived from multiple embryonic germ layers. And the imaging will typically show a heterogeneous mass containing different proportions of cystic tissue, soft tissue, fat, calcification, kind of all jumbled around. So it's generally disorganized compared to this looks more of an organized architecture. So the teratoma was still a possibility, but didn't completely fit this picture. And then again, the hematoma was another consideration. And the hematoma would vary in appearance depending on the age of the blood. And so we saw in ours that the cystic portion of the fluid did not change over time. And additionally, it would be uncharacteristic to have an internal solid mass inside of the free blood. And so a new differential considered was fetus in fetu, which is an extremely rare congenital development anomaly. And this is when there's abnormal incorporation of a monozygotic diamniotic twin during embryological development. So essentially, one of the twins is growing inside of the other twin. Okay, so that led us down to our case versus teratoma versus fetus in fetu. Those were kind of the two final diagnoses. And again, to highlight the most important part is organized versus disorganized mass inside of the tumor. So in our case, you can see it kind of looks more organized, which we'll see a better picture later. But the teratoma, there's not really any internal organization. There's a bunch of different kinds of tissue, and they're kind of displaced in a random order. And so now the final diagnosis was fetus in fetu, and this was after the surgeons removed the tumor, and this is while it had the capsule on top of it. But once they removed the encapsulated layer, this was the internal nodule that was found inside. And you can kind of see what look like to be like premature limbs, like feet and hands coming off the side of the mass. And so they did a radiograph of this, and you can see an organized vertebral axis going down the middle of it. And again, you can kind of see what are about to be like premature limbs with some bony features inside. And again, fetus fetu is extremely rare congenital development with an occurrence of about 1 in 500,000. And it's believed to result from abnormal embryological incorporation of one twin into the developing host fetus during early embryogenesis. And the retroperitoneum is the most common location, although there's some case reports of them being like in the skull or other parts of the body as well. And so imaging typically demonstrates a well-encapsulated mass with internal organization, and that's what will help distinguish it from a teratoma or a neuroblastoma. And finally, the teaching points. Again, it's an organized internal structure on imaging. The vertebral axis or other bony features is the key distinguishing feature from a teratoma. And as you can see, or we saw back in this one, that there was an organized vertebral axis, or there could be other organized bony structures as well. It's usually encapsulated and it's also non-invasive, so that helps distinguish from a neuroblastoma or another malignant process that may require oncologic treatment. And so recognition on imaging is critical in distinguishing fetus in fetu from the malignant mimics. And that's everything I have.
All right, excellent. I just want to say in closing, all of you did a great job, all great cases, including our 2 honorable mentions. And one thing I forgot to say in the beginning is we have several committees parts of the MRS. One of them actually is called the Foundation, which literally gets donations from radiologists or members of the group. But I was going to say is that the Foundation has agreed to give you guys, so the 5 winners, you will get a $100 gift certificate, and if it's going to be the same as last year, the prior years, you're going to get an Amazon gift card. So I will email you that information, and that'll come from the Foundation. So again, congratulations to all of you. And for those of you that are not graduating that are on the call, we'll be doing stuff in the fall. I don't know what our activity will be in the fall, but we'll probably have a couple of events. So Dr. Klein, do you want to say anything in closing?
Oh, just, even after knowing what these cases are, previewing all these cases, I still was on the edge of my seat with your presentations and the rarity and the incredible pathology that we just witnessed. So I love radiology. I'm never going to be bored and constantly engaged with excellent cases and presentations. So thank you very much, you guys, for submitting. Congrats on a really nice job. And then I do want to reach out because I have a couple ideas regarding the cases that were submitted as well. And for those that, I will reach out and discuss that. So.
Excellent. Well, thank you, everybody. And I wish everybody a good night and a good rest of your summer. Thank you, everyone.
Rocky, these are the best cases of, not even the residents can present these cases like this.
Oh, exactly.
These guys can deserve to be radiologists.
Yeah, these are incredible cases.
They are not medical students, not even radiology residents. Wow.
Absolutely.
Yeah, you guys, your presentations were like top-notch professional level presentation stuff too. Obviously well practiced and really well done.
Congratulations, all of you. Wow.
Yep.
Thank you, everybody.
Thank you.
Good night.
Thank you.
Thank you.